Hello, and thank you for your interest in our research study entitled Socioeconomic Disparities in Colon Cancer Survival, Revisiting Neighborhood Poverty Using Residential Histories. My name is Wiese. I'm a doctoral candidate in Geography and Urban Studies at Temple University in Philadelphia. The present study was funded by the National Science Foundation and is a result of collaboration between researchers at Temple University, Rutgers University, and Fox Chase Cancer Center. The objective of our study was to determine whether survival estimates by neighborhood poverty are different if the patient's residential histories were used to estimate poverty instead of the more commonly used residential location at the time of diagnosis. This study is unique because to date most population-based studies using cancer registry data examine cancer outcomes by neighborhood factors that are based on the residential location at diagnosis, so a single location only. However, when analysis is conducted using only location at diagnosis, we assume that cases are not mobile and neighborhood measures like census-tract poverty do not change over time. This limitation is mostly the result of cancer registries not collecting information about residential histories, but only a residency at the time of diagnosis. In this study, we linked all of the colon cancer cases from the New Jersey State Cancer Registry to LexisNexis administrative data to obtain residential histories. Using these residential histories, we were able to define census-tract poverty based on all residencies across the follow-up period and not just from the location of the time of diagnosis. Using Cox proportional hazard regression, we estimated associations between colon cancer survival and census-tract poverty measurements adjusted for individual factors and mover status. The study results indicated that 65% of all cases were non-movers, while only 35 have changed the residency at least once. Also, patients from impoverished neighborhoods changed residency more often than cases from affluent areas. Comparing the two models, hazard ratios were generally similar in strength and direction across census-tract poverty measurements. In the time-varying model, however, cases in the highest poverty category had a 30% higher risk of colon cancer death than cases in the lower category. Our findings suggest that residential changes after the diagnosis may be associated with the higher risk of colon cancer death among individuals who live in high poverty areas. This has important clinical and public health implications in regards to post-diagnosis access to care for treatment and follow-up surveillance. More research is needed to assess how geographic uncertainties about residential locations over time might impact model estimates, especially when considering different neighborhood variables, populations, and when spatial location is directly included in the models. On behalf of myself and my co-authors, I would like to invite you to read our full paper in the upcoming issue of Epidemiology. Thank you for your time.